Welcome in. Today we're going to discuss Chapter 8, Exercise for Impaired Balance. So you can read through some of these objectives. Okay, so some of the basic backgrounds and concepts. First thing that we're going to talk about is what we call postural control. And this is the control of body's position in space to maintain orientation and stability. So we challenge our patient's postural control in many different positions, such as sitting, standing. We can change the surface of, say, a chair that they're sitting in, or we can have them on a Swiss ball and really challenge that postural control. And we can do the same thing in standing with a Bosu ball, a foam pad, those kind of things. So it's just control of the body's position to maintain stability. Then we look at the center of mass. This is the point at which the body is in perfect equilibrium, and it's determined by finding the weighted average of the center of mass of each body segment. Now, I really want you to know this next component here, which is center of gravity. So what is center of gravity? Well, this is the vertical projection of the center of mass to the ground. So in an anatomical position, the center of gravity of most adult humans is located slightly anterior to the second sacral vertebra at approximately about 55% of somebody's height. So that's where our center of gravity is basically located. And then we have momentum, which is a product of mass times velocity. We're not going to talk much about the momentum when we're talking about balance, but center of gravity, center of mass, and postural control, big concepts for this chapter. Some more just kind of background knowledge and concepts. We also talk about the base of support. This is another big component of this chapter. And what is the base of support? It's the perimeter of the contact areas between the body and its support surface. So when we are starting out with balance for somebody who has really impaired balance or a loss of balance, we're going to typically start them off with a wide base of support, making sure that they are able to maintain that postural control that we talked about using a wide base of support. So using something like a bilateral stance with the feet spread pretty widely. And then as they become better at maintaining that postural control, we can narrow the base of support to feet touching in a bilateral stance. We could do a tandem stance. And then we can even take one of those points of contact away, and we can have them stand on a single leg, and we can perform single leg balance by decreasing that base of support. Something else that we're going to talk about in a lot of our different strategies for balance would be this limits of stability. And basically, when we're talking about limits of stability, these are the sway boundaries that we're really stressing out to try to maintain equilibrium without changing the base of support. So when we're thinking of something like a functional reach test, you're going to have your arm at about 90 degrees of flexion, and you're going to reach forward as far as you can without taking a step, without losing balance. So you're staying within that base of support. Okay. So the limits of stability are basically how far we can move, our hips, posterior, anterior, or how far we can move laterally, medially, without having to change our base of support by taking a step. And then don't worry about the center of pressure. We're not going to talk much about that. So let's look at balance control. There's a lot of different components that go into maintaining balance and having good control over that. First one we're going to talk about is the nervous system. So the nervous system helps us maintain a perception of our body orientation in space. And it helps with motor strategies for planning, programming, executing balance responses. So the nervous system plays a really large role in balance control. The next one that we talk about here is musculoskeletal contributions. So we're looking at postural alignment, maybe with a plumb line. We're doing joint range of motion measurements. We're looking at joint integrity. Is there laxity? Is there too much tightness? Are there contractures in the joint? What kind of muscle performance is the patient presenting with? Are they strong enough to maintain these positions? Those kind of things. And then we also have to look at sensation, especially for our patients with diabetes mellitus and other types of sensory loss issues. If they can't feel their foot on the ground, they're going to have a hard time maintaining their balance. You're probably going to have to go to that wide base of support and start from there before you challenge a narrow base of support. We also have cardiovascular, and a lot of people don't think about the cardiovascular system as really playing a large role in balance control, but it does help to, contribute to maintaining balance by making sure there's adequate brain perfusion to prevent loss of balance due to orthostatic hypotension or any type of alerted alterations of consciousness. Then we have our visual system that comes in next. This gives us basically the position of the head to maintain a level gaze, and it responds to the direction and the speed of the head movements. We have our somatosensory systems, our muscle spindles, our Golgi tendon organs, all the joint receptors, and the skin mechanoreceptors. We have our vestibular system, and the vestibular system is very important for maintaining balance. Receptors in the semicircular canals, or those SCCs, detect angular acceleration of the head, whereas the receptors in the otoliths detect linear acceleration in head position with respect to gravity. So a lot of your patients that come in with vertigo, we're going to be looking at this system here in great detail. Okay, so let's look at some of these different types of postural control. The first one here is what we call a steady state control, and this really just helps to maintain a stable upright posture while at rest. We have our reactive control, which is really stimulated when we have unexpected external perturbations. So something like standing on a bus and it accelerates really quickly. That's what we really rely on our reactive control in order to maintain our balance. That's an unexpected perturbation. Then we have our anticipatory control. This is a proactive postural change that occurs before and at the onset of a movement. So something that we do often in physical therapy practice is we challenge our patients' balance by having them stand on a single leg or in tandem, and we throw a ball at them, and we challenge, reaching and catching and all those kind of things. Well, that's anticipation, right? Your patient knows that you're going to be throwing the ball at them. They're kind of already anticipating what they have to do to maintain their postural control. So that would be anticipatory control, something that is proactive as opposed to, again, reactive. And then we have adaptive control. And this is basically what happens whenever we challenge these different types of postural control. So maybe somebody's having a very difficult time with this anticipatory control initially because it's just new to them and they haven't had a lot of practice or repetitions with this activity. But as they progress through their session or maybe their rehab phase, they get better and better at it. So this would be what we call adaptive control. They're adapting to those stresses and they are becoming more functional and better with their performance because of those extra reps, because of that practice. Okay, let's talk about closed loop feedback and open loop feed-forward systems. So a closed loop feedback requires some kind of sensory feedback. Okay, an example here would be maintaining balance while sitting on a ball. So you are going to get some kind of feedback from that ball, and you're thinking about what you have to do to maintain that balance. So this is, again, kind of like what you were thinking of when we discussed anticipatory control. We're getting some kind of sensory feedback. Okay, maybe we're anticipating it, and we are responding to that kind of feedback. A little bit different for an open loop or a feed-forward system. This is used for movements that occur too fast to rely on sensory feedback. So this would be kind of like your reactive postural control. So something happens too fast, again, standing on the bus as it accelerates, maybe you weren't ready for that acceleration. It throws you backwards and you're having to react to that, that input. But it was something that happened automatically. It wasn't anything that you were preparing for. And again, it's all of our reactive responses. Okay, this is something that you'd probably want to star as far as this slide goes, because we're going to talk about all of these different strategies for balance control. And these are going to be on your quizzes. We're going to talk about these a lot. So make sure you star this slide, and we're going to go over each one of these here in just 1 second. Okay, so this first one here, this little image, looking at the ankle, hip, and stepping strategy. There are a few other ones in there that we're going to discuss, but those are kind of some of the main ones that we use every day. So what is the ankle strategy? Well, the ankle strategy is basically for really small anterior to posterior perturbations, and it's not anything that is going to force you to change your base of support. So you can correct these small anterior posterior perturbations by activating this muscles distal to proximal. And some of the ones that you're going to activate, with these anterior posterior perturbations, these small perturbations, would be something like the gastrocnemius, the soleus, the tibialis anterior, and then as you move further up the chain, the hamstrings and the paraspinals for each of those perturbations. The next one here we have is called the weight shift strategy. So what is the weight shift strategy? This is when we shift weight, our body weight, laterally from one leg to the other. So something like a side step, trying to squeeze past somebody in a checkout line or in the grocery store or something like that would be considered, an example of a weight shift strategy. Whenever we shift our weight laterally, we're basically activating the hip abductor and adductor muscles. So those are going to be the main active muscles active during this weight shift strategy. And there are, of course, some contributions from the ankle inverters and everters as you change the position of your ankle by shifting your weight onto one leg. Next up, we have our suspension strategy. So this is observed when a person quickly lowers his or her body center of mass by flexing the hips and the knees. So in the image I have somebody jumping off of a box and they are going into a deep squat. The suspension strategy is really good for taking some of those compressive forces and kind of acting as a shock absorber. So again, we are going to flex the hips, flex the knees, and you're probably going to see quite a bit of ankle dorsiflexion in that movement as well. And usually, this is a combination of ankle weight shift strategies kind of with that whole suspension strategy moving forward. So another good example that I always like to think of for suspension strategy is maintaining your balance on a surfboard or a skateboard or a snowboard or something like that. You're having to quickly lower your center of mass to make a turn, to stop, do some of those things. That'd be a good example of something like the suspension strategy. And then the last two that we're going to discuss here would be the hip strategy and the stepping strategy. So the hip strategy is very similar to the ankle strategy, except for really the only difference here is that instead of a small anterior to posterior or posterior to anterior force, it's a rapid and a large perturbation. So this is used when ankle strategy isn't going to be as effective. So what happens with the hip strategy is we basically push our hips very far forward or very far backwards to try to maintain that center of mass over our base of support. So we're either getting rapid hip flexion or rapid hip extension instead of just dorsiflexion or plantar flexion as we see with the ankle strategy, but still anterior to posterior forces. And the last one here is the stepping strategy. This is when the center of mass moves beyond the limits of stability, or those sway boundaries that we talked about earlier. So if I push somebody, pretty hard from the back side, and they cannot push their hips far back enough to maintain that center of mass, they're going to have to take a forward step, change their base of support in order to maintain their balance. So as soon as somebody takes that forward or backward step, we're moving out of the hip strategy, we're moving out of the ankle strategy, and now we're performing something like a stepping strategy. So how do all of these balance strategies and things like that relate to control when we're lifting objects from the ground? Well, we are going to shift our center of mass depending on what we're picking up, like something in front of us. We're obviously going to get whatever we're lifting close to our body, and that alters the position of the center of mass. So it's shifted forward whenever we're lifting something that's in front of us. It shifts forward with trunk and leg flexion, creating internal disturbance to balance. Then we also kind of look at the anticipated weight and momentum needed to lift an object. So if somebody is anticipating that something is going to be very, very heavy, they're going to try to use their momentum and maybe lean backwards into that lift and use their momentum to get that weight up. If they overestimate how heavy it is, right, they're going to fall backwards. They're probably going to have to change their center of mass. If they really underestimate how heavy an object could be, then you may see them fall forward, or if the weight is too far out in front of them, or whatever load they're lifting is too far out in front of them, you may see them fall forward and have to change their center of mass. And that creates that loss of balance. Yeah. There are also a lot of different lifting styles that we utilize in basic everyday physical therapy, and you've had some skill competencies in one of your courses that looks at those different lifting styles, such as a deep squat, a stoop lift, a golfer's lift, those kind of things. So depending on which lift you're utilizing, you're going to have to teach your patient about balance and maintaining that center of mass over their base of support. And this is where it becomes really important with our lifting instructions. So you guys have done a great job so far in this semester by performing these lifting techniques and instructing your patients on how to do that safely and appropriately. What are some of the risk factors for falls among older adults? Well, the number one thing that we look at here is a history of falls. That's kind of number one, okay? If a patient has a history of falls, the likelihood that they're going to fall again is very high. Something else that we really want to look at would be the use of medications and how many medications a patient is taking. And along with how many medications they're taking, what types. So some of the medications that you really need to be aware of would be something like hypnotics, sedatives, antidepressants, tranquilizers, antihypertensive drugs. All of those lead to dizziness and other types of side effects that could really affect somebody's risk for falling. So I would always look at the history of falls and the types of medications, the number of medications that your patients are taking. Usually if the patient is taking more than 4 medications, that increases their risk of falling significantly. The next thing that we look at is their gait pattern, how well they can maintain that postural control in different positions, and any other types of mobility deficits. So if you notice that somebody has a very short stride and step length, and they don't maintain their balance very well with a narrow base of support, that could be something that would lead to, again, increased risk of falls. If somebody has visual deficits, they can't see the floor, they can't see the type of environment that they're stepping on, then obviously we're going to see some risk factors for falls there. Other types of neurological impairments, if there is muscle weakness, maybe lifting objects from the floor can be very difficult. So let's say somebody has weak quadriceps muscles and they go to bend their knees to pick something up off the floor and they can't control that movement eccentrically. Well, that's a risk for falls too, right? Maybe they have utilized some other types of lifting techniques, such as a straight leg lift, but again, that is a risk for falls. If they have heart rate and rhythm abnormalities, this could create a huge risk for falls as well. They get lightheaded, those kind of things. They get really hypotensive. That will put them at risk for falls. And that leads right into postural hypotension. So again, just make sure that whenever we're transferring our patients or they're doing an independent transfer, we're aware of the medications, because again, a lot of these medications can create hypotensive responses. So as they're transferring, make sure that you're monitoring dizziness, lightheadedness, those kind of things, because we really want to avoid falls at all costs. Foot and footwear problems. We talked about sensory deficits earlier. So if somebody has sensory deficits and they can't feel the ground that they're stepping on and they can't get that kind of feedback that they need kinesthetically, then there's a risk for falls there, as well as environmental hazards such as throw rugs, small pets running around their feet, cluttered environment. All of those kinds of things can lead to falls, and I've seen that happen many times in clinic. Okay, so management of impaired balance. So what do we do whenever we notice that somebody is impaired with their balance? We're going to obviously work on a lot of balance training. And there's a lot of different types of balance training activities that we can perform with our patients. So let's look at a few examples of these different types of tests that we can use to gain some objective data as well as train our patients for balance. So the first one here, we're looking at steady state static balance tests. So basically what we're saying here is they're going to be static, right? They're not moving. It's not a dynamic balance activity. We're just seeing how well they can maintain postural control in standing with different bases of support. So the first one we're going to look at is the Romberg test. So the Romberg test tests the patient's ability to stand with the feet parallel and together with their eyes open and then closed for 30 seconds at a time. And if we want to challenge them even further, we can perform something that is called the sharpened Romberg test. And it's very similar to the regular Romberg test, but instead of having their feet together, narrow base of support, now we're going to put the patient in a tandem stance. So heel to toe, one foot in front of the other. We're going to cross their arms at the chest and then close their eyes for 1 minute. So that's the difference between the Romberg and the sharpened Romberg test, but both static balance tests. Then we have the single leg balance test, and it is exactly what it sounds like. The patient's going to stand on one leg without shoes, with their arms crossed, or you can put their hands on their hips without letting the legs touch each other. And you're going to do that 3 times, and you're going to take 30 seconds, use 30-second trials for each leg, and you're going to use the best or the mean time for those different tests. And then there's the last one here called the stork stand test, and this is where your patient is going to go onto a single leg, and they're going to put the other leg that's kind of hanging out on the knee or right behind the knee, almost like a tree pose in yoga. And you're going to do the same thing. You're going to look for 20 to 30 seconds as far as your trials go, and you're just going to mark when they need to put their foot back down to maintain their balance. And here are some different dynamic balance tests, kind of anticipatory control tests that we can perform. So dynamic just means that we're moving. Okay, there's a lot of movement going on with this balance, and one that we like to do often is the 5-time sit to stand test. And again, exactly what it sounds like. Your patient is going to cross their arms over their chest, and they are going to go from a sitting position to a standing position 5 times. And they're going to do this as quickly as they can. And the reason that we would do this is because we want to identify if a patient is at fall risk when moving between a sitting and a standing position. Then we move on to our anticipatory controls and tests. So the one that I mentioned earlier was the functional reach test. So again, we are anticipating reaching our hand forward, let's say on like a ruler or a meter stick. Okay, so we're going to have to perform something like a hip strategy to push our hips back, lean our body forward in order to really reach as far forward as we can here. That's my hand. Okay, nice little guy here. happy. Then we also have our STAR excursion balance test, and this is something that you can click on in your lecture, and you can watch what the STAR excursion balance test is, or the SEBT. Very similar to a Y balance test, except for it includes more movements. So there's going to be 8 movements in the STAR excursion balance test as compared to 3 with the Y balance test. But this is another good anticipatory control that tests anterior, posterior, lateral, anterior, posterior, medial stresses. And again, if you're curious about that, I encourage you to click on that video and watch it. But we did watch that one in class. And then we also have some of these reactive postural control tests. So a push or a pull test. So this is basically where we are trying to see if somebody can use that stepping strategy in order to maintain an upright posture and avoid falls. So with a push test or a pull test, you are going to either stand in front of the patient or behind them, and you're going to push on them and say, okay, I'm going to release you in a second, and I want to see how you react to this perturbation. So you're going to push them, let's say, forward from the back side, and as you let go, their momentum is going to be moving backwards. So they're going to have to take a step backwards in order to change their base of support, maintain their balance. So that's really all those are. We're not going to talk about the modified clinical test of sensory integration on balance, but that is something that you might see in clinic. And then we also have a lot of these other functional tests. These are good objective measures that you can utilize and you probably will utilize in clinic. And the first one, again, I have a video linked to it, is called the Tinetti Performance Test. A perfect score on this test would be a 28. And we typically use this for a lot of mobility assessment, those kind of things. We have the timed up and go test, which is used very, very commonly in clinic. There is no score associated with this. You're just taking the time that it takes for your patient to stand up from a seated position, walk 10 feet around a cone, turn around that cone, come back and sit down. So that's a really common one that you're going to see in clinic. We have the Berg balance scale. A perfect score on the Berg balance is a 56, and it incorporates lots of turning, those kind of things. Kind of similar to a Tinetti performance test, where you're doing multiple tests and getting a score based off those. And then we also have the 4 square step test, which is another time test. There are a lot of other coordination tests that you're going to be performing in semester 4. So a few of the ones that you may see in the near future would be rapid alternating movements, the finger to nose test, finger opposition, fixation position hold, heel on shin, pronation supination test, tapping of the foot or the hand, and then throwing and catching a ball. So those are all good coordination tests, and again, you'll be seeing those in semester 4. So when we talk about progression of balance activities, sometimes students have a hard time with this, and even just regular clinicians have a hard time of progressing balance activities. By no means is a single leg balance the hardest thing that you could do for your patients, nor should it be the last progression that you are utilizing with your patients. So we can kind of look at this example here that I have. So I started with a patient in sitting with their eyes open, and I'm manually applying some postural stresses, so some perturbations, maybe posterior anterior, maybe lateral. And then I can have them, as a progression, sit on an uneven surface and see if they can just maintain their balance there. Then I can move from seated balance to a standing balance, and I'll start with a bilateral stance. I can start with a wide base of support and then move to a narrow base of support. And then I can even go to a single leg stance and then change the surface if I need to. Once I move from the just regular standing, maybe like a soft surface, I can go to the trampoline, and I can include some hopping to make it a little bit more dynamic. I can also use foam padding for a double leg or a single leg stance. I can add ambulation. Typically we have our patients walk on kind of like a little balance beam, and it's a soft foam balance beam. So they're doing a tandem walking on a soft surface, and we typically do forwards, backwards. We can add hurdles in there as a progression as well. And then we can always utilize balance devices such as a BAPS board or a rocker board or a really cool biodex. I've seen these in a few of the clinics, and they're some pretty high-tech pieces of equipment, and you can play games on it, so it makes it really fun for your patients. But it gives you some real-life feedback, and it actually records your results, so you have some objective data to look at following that. As far as safety goes during balance training, make sure to always use a gait belt, especially as a student just entering into clinical rotations or as a new grad entering into the workforce. Always put a always put a gait belt on to maintain safety, unless you absolutely don't need one, but you can never go wrong using a gait belt. When you're guarding your patient, you want to stand slightly behind and to the side, typically with one arm on the gait belt and one arm on the shoulder. Just be cautious about the shoulder, putting a hand on the shoulder, as you could throw off the person's balance and actually cause a fall. So just be really safe, make sure you're guarding your patients. Have handholds available just in case, so always performing balance activities in the parallel bars is a good idea, especially if you know your patient is at a fall risk, or if they have an assistive device like a four-wheel walker, a rollating walker, then just have that available in case you need them to grab onto something. Make sure to stay away from sharp edges, dangerous areas like a pool or something like that. And if somebody is really high risk, maybe have one person in front and one in the back. And always check your equipment that you're using. Okay, so that does it for this chapter. Just remember to really look at those different strategies for maintaining balance. So ankle, hip, weight shift, suspension strategy, stepping strategy, those are going to be really important, as well as the terms like base of support, the center of gravity. If you look at all that, then there's no way you can go wrong on your quizzes or any other exams. Thank you so much. I hope this was helpful, and I will see you next time.